Now coming to few conditions which can progress to adult stage. The first and foremost is the adult tetralogy fallow. Tetralogy fallow which was diagnosed in the childhood. Now what happens in the adult stages? Tetralogy fallow, as the name indicates, it has 4 defects of various physiological significance. The first is ventricular septal defect, varying degree of right ventricular outflow tract obstruction, right ventricular hypertrophy, and there is overriding of aorta. Here the typical clinical significance is hypoxia resulting from decreased pulmonary blood flow. To look at the anatomy, the first and foremost is the right ventricular outflow tract obstruction. Here the blood from the right ventricle cannot enter into the pulmonary circulation. That is the most important cause for hypoxia. The second is, because of this obstruction, your right ventricle is hypertrophied. The blood from the right ventricle has gone into pulmonary circulation, but there is obstruction. So, the right ventricle contracts vigorously to push the blood in. So, it undergoes an hypertrophy. That is the second abnormality with regard to tetralogy fallow. And third one is a ventricular septal defect. The blood from the right ventricle goes into the left side because your right side pressure is high and there is a blood which goes from the right side to left side of the heart and oxygenation does not happen and there is hypoxia. That is the third defect, and this is perimembranous and a malaligned VSD. And the fourth important part is the overriding of the aorta. What do you mean by overriding? The blood from the right ventricle as well as the left ventricle via VSD goes into the aorta. So, the aorta receives a mixture of blood from the right and the left ventricle due to the overriding. So, what you do in early stages in the newborn period or something, you can do shunt. The shunt can be a classic blood-lock toxic shunt or a central shunt or a modified blood-lock toxic shunt. And as you do the shunt, you allow the child as well as the pulmonary artery to go and you do an intracardiac repair at a later stage. And by doing shunt, you augment the pulmonary blood flow and the pulmonary blood flow increases. And usually you do a shunt for candidates who are not suitable for an early complete repair. The PA may not be of adequate size and you may not undergo the complete repair. So, you do a shunt, increase the pulmonary artery size and then do the surgery at a later stage. And the later stage means you complete the repair in first year of life. Degree of pulmonary stenosis protect the lung from over circulation. The blood may not reach the pulmonary arteries, but at the same time there is adequate pulmonary blood flow which is available for growth of the pulmonary artery, and this patient ultimately may not require repair at the early period. You can do the repair at a later stage. Type of repair and functional status of the repair should be obtained in the adult period. What repair was done, what size of shunt was put, how much the saturation has improved, all the information you should have when the child goes into the adult period. Now coming to another important surgery which is done for single ventricle and the child goes into adulthood, which is called the Fontan, which was performed in 1970s by Fontan and Kuster for a case of tricuspid atresia. This is known as Fontan procedure or toto-cavernous anastomosis. By meaning of toto-cavernous, your IVC blood and the SVC blood is connected to the pulmonary artery. So, it is called as toto-cavernous anastomosis. It separates the pulmonary blood flow from the systemic circulation. The goal is to divert the deoxygenated venous blood directly and passively, that is very important, directly and passively to the lung through the pulmonary artery, thereby allowing the single ventricle to pump the oxygenated blood to the systemic circulation. Here you bypass one ventricle and put the systemic venous blood into the pulmonary circulation, thereby it goes lung for oxygenation and then return to the single ventricle and pumped into the systemic circulation. The principle is applied to many type of single ventricle patient, usually as a series of 2 or 3 stage procedure. The first stage you do Norwood, second stage you do Glenn, and then you do third stage as a completion Fontaine. Here you can see the systemic blood from the lower and the upper part of the body bypass the right ventricle and go into the lung through the pulmonary artery, and from the lung it returns to the single ventricle, and this single ventricle pumps the blood into the systemic circulation. This is the Fontaine circuit. So the principle is your superior vena cava blood and the inferior vena cava blood is directed to the pulmonary artery, and from the pulmonary artery it goes into the lung, get oxygenated and return via pulmonary vein into the systemic ventricle without an intervening right ventricle or without any intervening ventricle. And here there is no mixing of the blood. That is very important. Your SVC and IVC blood is conducted to the pulmonary artery, it goes into the lung, get oxygenated and comes into the systemic ventricle and pumped into the systemic circulation. This is the principle behind Fontaine circulation. And coming to the survival with Fontaine circulation, it is usually performed between 2 to 4 years of age, and it results in separation of pulmonary and systemic circulation. Occasionally, adult present without separation of circulation in single ventricle, and if no intervention is done, the patient presents with severe cyanosis and severe ventricular dysfunction. Even after completion Fontaine, many patients experience decreased survival beyond 15 years after surgery. The survival rate after age 16 is around 90% survive till 30 years of age and 80% survive till 40 years of age. The survival is significantly worse with atriopulmonary connection than with cavopulmonary connection. The cavopulmonary connection has slightly better outcome than atrium. You connect the atrium to the pulmonary circulation. And the complications with Fontaines include impaired systolic function, impaired diastolic function, your pulmonary vascular resistance goes up, and there can be refractive heart failure. And here you have to understand that heart failure therapy to treat two ventricle may not be as efficacious as what you do for single ventricle. Treating heart failure with two ventricle is different, and treating heart failure with one ventricle is totally different. They can be thromboembolism, protein losing, enteropathy and arrhythmias.